So, hi, good afternoon, everybody, and thanks for this chance from Ash and the partners to speak to what I do. I'm going to touch on a lot of the themes that have been spoken about already. So, I only work in general hospitals, so I'm a psychiatrist who pretty much for more than 30 years has worked in general hospital settings. And that's my hospital there on the left, the Royal London Hospital. If you walk around long enough anywhere in London, you'll see the two peaks of the Royal London Hospital. I took this photo originally because there were 4 people smoking, and then I lost my nerve to shame them, by showing their picture around the place. But I took it for another reason. It is a lovely picture of my bike locker there at the bottom, and that's what my bike locker looks like outside the no smoking area of the hospital. There are several signs that say no smoking, and that's what the reality is of working in a general hospital, where we do everything imaginable to help you and your total health experience, except talk about smoking and enforce our laws. And in the middle of that gap between the beauty and the policy is the reality. In the middle is just something I was working on last week with David Shires, who many people will know, one of the great champions of physical health checks and physical health in people with severe mental illness. And this will be the new Leicester adaptation guidance for every mental health admission. So it's we've kept that lovely word varenicline in it, even though there was a big move because we can't get supplies at the moment to remove varenicline from the guidance. We've kept it in the guidance with the asterisk saying subject to availability. So I'm going to speak about some of the positives here and maybe some of the negatives as well. So nationally, we have a fantastic achievement thanks to public health colleagues and changes in the price of cigarettes and loads of other things to reduce smoking rates. But unfortunately, when it comes to severe mental illness and many aspects of mental health problems, I'm afraid those rates are rising. Okay, so the lockdown was not all about learning a new language and baking banana bread. For a lot of our patients' mental health problems, some of the old stuff crept back in, and we have to acknowledge that. Certainly where I work in East London, we're seeing SMI smoking rates greater than 40%. Okay, you've heard about housing. In homeless people, that rate can go above 70%. In people attending an addiction service, it's up to 90%, okay? So smoking absolutely is still top of our agenda. And lots of what I'm going to say applies to not just severe mental illness, but personality disorder, dementia, intellectual disability, addictions. They're all reasons to think about it. If you have SMI, each year you're more likely to admit it to a general hospital than a psychiatric hospital. And when I talk to our leaders in NHS England, they seem to think they have a picture in their mind of what a psychiatric patient looks like, and they put he or she immediately into a psychiatric facility, because that's not where they spend their lives. They spend their lives in the community, but sadly, between 15 and 23% will have a general hospital admission, or they'll see people like me in general hospital outpatients as well. There's now good news with IAPT, the improved access to psychological therapy, the talking therapies. They will ask about smoking. That's not fully implemented yet. But I suppose they're people who really understand psychological issues and behavioural issues, but now we need to teach them how to understand smoking. In my general hospital, everybody knows about the bad effects of smoking. They just don't know much about motivational interviewing or asking people how they might quit or helping them quit. And they know next to nothing about mental health problems, okay? Despite the fact that they're very prevalent in a general hospital. And this is something I've worked on and published this year, where just like the audience this morning in the poll, poverty and inequality are absolutely at the centre of this, okay? I will never refer to smoking as a lifestyle choice. It's not a lifestyle choice in somebody who grew up with disadvantage, who has constant cost of living crisis concerns at the moment, or who has chronic stressors right now with housing and other issues, but also people who had adverse childhood experiences. So all of this bad stuff from the centre of this diagram drives the smoking, the alcohol excess. And think about it, when you smoke and you drink, you're more likely to have the adverse effects of smoking come to you because you're drinking, and the adverse effects of drinking come to you because you're smoking. So lots of these will interact. The bits we don't do enough about in psychiatry are the interaction between risk-taking behaviours and smoking, because a lot of smoking is about self-soothing. And risk-taking behaviours and self-soothing are two sides of the same coin when people are in crisis. And it's very important for someone like me, who works a lot in emergency psychiatry, to think about how the sort of behaviours you and I take for granted, the slow breaths Mark was giving us, they go out the window when someone is in crisis. So this is something I think about in public health terms. The other negative, I'm afraid, is this is the NHS England official diagram pre-COVID when they were collecting data. And they were noting that the difference in expected mortality between people with severe mental illness and the rest of the population was different by rising factors, and it rose every year since austerity. Okay? Every single year the difference rose. Does anybody know where that graph is now? Yes, where is it? Do you know where it is? Do you know the rate? It's up there. It's 5 times now the expected mortality. The rates change in the UK. I'll show you a lovely graph of England. These are figures that came out just last week. So you're between 2.5 and 7 times more likely to die before the age of 75 if you have severe mental illness. And the government's own data speaks about 2/3 of those deaths are from preventable physical disease. So they're exactly the sort of grim diseases I was showing you in the slide. This is what England looks like. You'll be interested to know that where we are right now, where I work in East London, are one of the worst parts of the country for premature mortality. And this maps very directly onto deprivation, and it maps onto smoking as well. Something's happening out there in West London and Hillingdon. I haven't figured that one out yet. If anyone is from Hillingdon, they can explain that to me. But if you look at the map of deprivation in the country, this is exactly where the mortality is magnified, and where also there are higher rates of smoking. Spare a thought for the Isle of Wight. That used to have the best results in terms of premature mortality in England, but something has happened in the last 15 years. I suspect it's loss of community. There may even be a sort of second home blitz on the island, but lots of stuff there that isn't about hospitals, but is about inequalities are being magnified on the Isle of Wight. So lots of reasons to focus our thought. But I'm going to speak about general hospitals. I always argue that the 1 in 4 of us who have mental health problems, we're not a different species, but sometimes the challenges are different. And as I said to you, the rates are even higher. And we do live in an age with growing mental health awareness, not growing mental health service funding, by the way, but just growing mental health awareness, which does actually bring its own pressures as well. And I think through this group, we're getting the message out that cigarettes don't soothe you. They make your depression worse. They make your anxiety worse. They will make your psychotic episodes more severe and of longer duration. So we're getting that message out. Don't start me on cannabis, but that's absolutely the message we need to get out to people. And you've said earlier today, many of the speakers talked about people being slightly more addicted, but that addiction is added to by tobacco poverty and social isolation as well. And I like to think of the general hospital patient journey when they're an inpatient, not as a patient journey, but more like a roller coaster, long periods of boredom, no Wi-Fi signal, nothing's happening, the ward round didn't show, I waited for my test, that was cancelled at the last minute, I'm not at work today, Monday. Rosanna will tell you everybody's x-ray gets cancelled on a Monday because something has come in at the weekend that will bump them from the agreed time of their MR scan, etc. So general hospitals are very unpredictable places, and I guess within that context we see smoking as a default. It is true there are different challenges on the psychiatric wards to the community teams, and generally speaking we do have nicotine replacement in general hospitals, but it's kind of a one-size-fits-all. You're prescribed a patch, and if you're a hairy, sweaty man, it just falls off you, yeah? And it's certainly true to say that when we give NRT, we should be giving 2 forms of nicotine replacement, and we should be co-producing with that person what form of nicotine replacement suits them best. I do, when it was available, was using Varenicline at clinic. It's not possible to get it on the wards even before the scarcity of Varenicline. So something wrong with the systems there. And the general hospitals have not moved to a liberal policy on e-cigarettes, okay? So it's not the moral panic that there's a 14-year-old who's smoking them or that they're in candy floss flavours. That's not the issue. The issue is for somebody who's smoking tobacco, to get them to make the transition to an e-cigarette is the smartest move, because in 6 weeks their respiratory complications will be down, in 6 months their clot complications will be down, in 2 years their MI risk will be down. All of those things are positives for people, but I think in general hospitals we're way behind the curve. This is not one of those talks where I berate everything, because the national leadership is absolutely excellent on this. So Public Health England, one of their great strengths was their Stop Smoking team. And I would argue what they're doing now in OHID is gathering the evidence, and this evidence is knockout, isn't it? That the evidence for behavioural support plus nicotine replacement plus varenicline is off the scale, okay? As a clinician, I haven't had good experience of bupropion because my patients don't tend to tolerate it, and I haven't had many quits when I prescribed it. It's supposed to be an anti-anxiety medicine. I've seen patients get anxious on it, so I've really struggled with it. But there's OHID reviewing the evidence. It's very, very strong effect sizes, okay? And they're also looking into the real tough times in getting varenicline now that it's gone from being a trade name drug to a generic drug. And we had some discussion off the line about cessation that's available it's the #1 smoking cessation medicine in Poland. So I've had conversations with Peter Hayek about it to try and get some supplies of that as well. But I have to say OHID are all over this, as indeed are NHS England, because I think we are seeing great leadership. I'm sure you've come across a GP colleague from the Midlands, Bola Owolabi, and her Core 20 + 5 leadership. Smoking crosses all of that. It's a really good thing to look up if you're trying to convince local clinicians what to do in this area to help them understand inequalities, perhaps for the first time. I would urge you to go to that work. Sanjay chairs the stakeholder group I'm a member of. There's the REC Psychs Quit Pro. There's loads of national leadership coming up. What's not so good is my clinicians in the general hospital give me the same routine I used to hear from psychiatrists, and that has changed where I work, but I used to hear from psychiatrists, it's all they have, it's a human right, whatever that means. It's not all they have, and we know that from our work today. When people do get to leave the ward, it's a good thing, and I mean a general hospital ward, and I absolutely want to pair that leaving the ward with sucking on some e-cigarettes or taking some nicotine replacement, not sucking on a cigarette. Because even if you know nothing about behavioralism and Pavlov, if every time you leave a stressful situation, you put a lit cigarette in your mouth, that's what you think is reducing your stress. And it's not. It's probably a combination of the change of environment, the people that you're with. I was making the point at lunch, why do people leave to smoke? Because your boss doesn't smoke. Yeah? There's a really good reason to leave an environment, where people that you don't want to be with don't smoke. So why don't you go outside but actually you can break that pairing. You can go outside, you can suck on an e-cigarette. It's a really positive replacement from tobacco, because as you know, anything is better than tobacco. But there is this gap, isn't there? There's the policy to practice gap, there's the training gap. We do get our general hospital doctors to measure, say, alcohol stuff. They do the smoking check, as in, do you smoke, yes or no? But at that point, they are not being offered very, very brief advice. So just 2 more slides. I'll keep to time, Jim. Yeah. And what did I want to say were the changes? I certainly think keeping tobacco on the agenda in a general hospital is absolutely key to this. Now, that's easy for me to say, harder to implement. One of the problems is the fragmentation within even general medical specialties, because cardiac think smoking is theirs, and they talk about it in terms of your cardiac health, but the respiratory guys 2 doors down are saying exactly the same thing, and they don't share any plan, any policy, any resources on that. And then they think mental health is separate to that, and it's not. It's the same people. And that's something that's very difficult, and I challenge this kind of either-or thinking. And I heard from the other groups that they're using their trust comms effectively. That's such a good thing to do. So people usually get a bit of a feel-good boost from tweeting or whatever. There are ways to do that to get people engaged. I think we need not just electronic reminders for clinicians, but we also need it to be brought up in supervision. How many people did you help towards a quit? What do you do about smoking? How's your smoking training at the moment? And we can do that in supervision for all staff. I think it's relevant to staff who work as porters, security guards, because they're the ones who are going to have to enforce remember that sign that says no smoking outside the hospital? That means nothing. They're the ones who are going to have to engage with that. So lots of stuff on policy and practice. And it is a tough one, because when I thought about this whole theory of change, we don't need more research. With all due respects to Kings who want to get more grants, we don't need more research on this one. So we have all that. We have the systematic reviews, but there is this gap as to how we do it. I think QI seems the natural route. We do establish the norms. We do embed the learning. But I would argue there's probably deficits in supervision that we need to address. And if you look at behavior change in the raw, everybody knows you hug, you nudge. We are going to need to give people the occasional smack, particularly staff, about smoking underneath the no smoking sign. Okay, so that's something we need to think about. If Mary Yates was here, she would tell you how she doesn't just take the tobacco product, well, she's retired now, but she would destroy people's tobacco products. Now that may be, crossing a line, but it is true to say that as we get into this area, to keep it on the agenda, we do need to do things a little bit more proactively, okay? So I know Dominic Raab would say robustness, which is another word for bullying, but I'm just saying proactive. So thank you for your attention. Questions?